This meeting is being recorded.
We will be continuing with the diabetic retinopathy, which Dr. Cibiram started. This meeting uh, is from Dr. Cibiram's slides, which he was discussing from last time. Last time he discussed all the risk factors and the pathogenesis of diabetic retinopathy. So today we will be starting with the classification. So classification of diabetic retinopathy. The history about the diabetic retinopathy classification is why it was actually made, why classification was made was to facilitate the communication among the doctors and the researchers. 1968, the first US Public Health Service held the first symposium at the Early House in Warrington, Philadelphia, to develop this classification system for the diabetic retinopathy. That's why the first classification for the diabetic retinopathy was known as the Early House classification system. It used 5 standard photograph fields in which the field 2 was centered on the foveola. Field 4 and 5 were just above and below the foveola, respectively, and field 1 and 3 were nasal and temporal to the foveola. The fungus lesions, that is, the hemorrhages, microaneurysms, lipids, neovascularization, were classified into one of the following categories. These were absent, mild to moderate, or severe. However, with only 3 levels of severity, graders used in this classification, they often found it very difficult to reach any consensus. The system, therefore, felt very short in its ability to communicate with the consistency among the researchers and the doctors. So it kind of failed. That's why it did not define the distinction between mild to moderate and severe lesions. And the result was that most lesions were categorized as mild to moderate category. So there was more of lumping and less of splitting. That is, less of them were changed to severe NPDR or severe diabetic retinopathy, and more were classified as moderate diabetic retinopathy. And this classification was not enough. Nobody was happy. So the next classification which came after this early house classification was the DRS classification, that is the diabetic retinopathy study classification. It was created the modified early house classification system with a greater degree of splitting. So two additional photographic fields were analyzed, that is the field 6 and 7, which was supranasal and inferonasal to the optic nerve head respectively. In addition, more gradations of severity for the individual components like neovascularization, IRMAs were added, and the primary question asked by the DRS study was whether the photocoagulation helped to prevent the severe visual loss from the PDR, and eligible patients either had PDR or severe NPDR in this study. So as we can see in this field 2 is centered around the foveola. Field 4 and 5 is up and down of the foveola. 1 is nasal to the foveola and 3 is temporal to the foveola. 6 and 7. 6 is supranasal to the disc and 7 is inferonasal to the disc. This is the modified early house classification, and this is all area in the posterior pole. So DRS classification of non-proliferative diabetic retinopathy should have any three of the following characteristics, that is the soft exudate present in minimum of 2 of the photographic fields 4 to 7. IRMA definitely present in more than 2 photographic fields of fields 4 to 7. What are the 4 to 7 fields? 4, 5, 6, 7. Not in these 1 to 3, but in 4, 5, 6, 7. So venous bleeding definitely present in more than 2 of the photographic fields 4 to 7. Hemorrhages are microaneurysms of the severe category, that is more than standard photograph 2A in more than one of the photographic fields 4 to 7, or IRMA more than standard photograph 8A, that is more than 2 of the photographic fields 4 to 7 and definitely present in the remaining 2 fields. So, along with this, a British classification also proposed an international classification under the National Screening Program for Diabetic Eye Disease in the United Kingdom. Despite the classification uses a different nomenclature, the meaning of them is practically the same. like no diabetic retinopathy is classified as RO. Background retinopathy is R1. That is the findings of mild NPDR to moderate NPDR. Pre-proliferative is graded as R2. Findings of moderate to severe NPDR. Proliferative is graded as R3. And whenever maculopathy and photocoagulation are classified as absent, that is MO, maculopathy absent, and PO, P not, that these both are absent, and when they are present, it is classified as M1, P1. After this came the ETDRS classification of the diabetic retinopathy from the ETDRS study, which classified mild NPDR as at least one microaneurysm and criteria is not met for more severe retinopathy stages. Moderate NPDR was hemorrhages or microaneurysms more than standard photograph 2A and oblique, or it should not be always present, but it can be present, cotton wool spots, venous bleeding, erymas, and criteria not met with the severe retinopathy. This is the standard photograph 2A, and it sets the intermediate standard for the hemorrhages and the microaneurysms. We can see there are a number of microaneurysms in this field along with hemorrhages. Severe NPDR was cotton wool spots, venous bleeding, and eryma, definitely present in at least two of the photographs of the field 4 to 7, or two of the three preceding features present in at least two of the fields 4 to 7, and hemorrhages present in the fields 4 to 7 more than standard photograph 2A in at least one of them, or eryma present in each of the fields 4 to 7 and more than standard photograph 8A in at least two of them, and the criteria not met for more severe retinopathy. Very severe retinopathy, very severe NPDR means two or more of the above these features. If only one of these things is present, then it's severe NPDR. Very severe is two or more of these features present. So we can see with the modified earlier house classification, we are seeing only the macular area. So then these peripheral fields were added. So according to the area, so temporal to this was peripheral field 3, temporal more upper side supratemporal will be peripheral field 4, this will be peripheral field 6, this will be peripheral field 7. And the ETDRS standard grade is involving on the macula, and it is based on standard 30 degrees field. This you can show standard photograph 8A in which the arrows, you can see the arrow. It is a subtle white patch of a wispy border showing a cotton wool spot. And you can see the arrowhead, which where several areas of eryma are visible as abnormal, tortuous, dilated retinal vessels, and they connect from one vessel to the other vessel. The staging. This is a fundus photograph of a severe NPDR or oblique PDR. This is the rectory photograph of the same area of the retina. This is the early stage of the FFA in which we show that all the microaneurysms are there. And this is the later stage where we see the microaneurysms leaking and causing leakage. So microaneurysms can leak late. Early PDR, we can see the new vessels like this, like a cartwheel or a bunch type appearance, grape like appearance.
This meeting is being recorded.
So as we can see, these are the new vessels, new vascularization, which we can see. And we can see the NVD also. High risk PDR is what? When the new vessels are within 1 disc diameter of the optic disc, it is labeled as NVD, and it should be more than standard photograph 10A, which shows approximately 1/4 to 1/3 of the disc area with or without vitreous or a preretinal hemorrhage. With or without specifically has to be focused. Or vitreous or preretinal hemorrhage accompanied by new vessels, which can be either NVD or standard photograph 10A, or the new vessels elsewhere having more than 1/4 disc area or the half disc area. So this is the standard photograph 10A showing the new vascularization disc covering at least 1/3 to 1/4 of the disc area. Next is the high risk PDR. Here we can see there is an NVD near the disc, and along with that there is the NVE. Here also, and this is the late photograph, and these black spots along with the white edges is the old photocoagulation mark. What is CSA mean? Retinal thickening at or without. Retinal thickening at or without, at or within 500 microns from the foveola. This is called clinically significant macular edema or hard exudates, which are around 500 microns from the fovea, along with associated retinal thickening, or around one disc diameter of the retinal thickening, which is around one disc diameter from the fovea. All these things are labeled as clinically significant macular edema. What is advanced diabetic eye disease? What is advanced diabetic eye disease? In advanced diabetic eye disease, there will be the hemorrhages, either preretinal or retroholoid, infragel, or both. There will be a fractional retinal detachment caused by the progressive contraction of the FPP over the areas of the vitreoretinal attachment. There can be rubeosis iridis, that is the NVI, and which might occur in the eyes with PDR, and if very severe, which it might lead to neovascular glaucoma. NVI is particularly common in the eyes with severe retinal ischemia or persistent RD, which follows after unsuccessful PPV. So these are the examples of the advanced PDR. Here we can see the hemorrhages, subhyaloid hemorrhage along with the fibrovascular membrane. Here we can see the fibrovascular membrane causing the traction at the macula. Here we can see again a fibrovascular proliferation along with the immature proliferation over the macula with an ERM over the fovea. Here we can see a persistent FPP just behind the lens area. So now we follow the American classification of the diabetic retinopathy, which show that there is no apparent retinopathy when there are no abnormalities, mild NPDR when there are microaneurysms only, moderate NPDR, it is more than just microaneurysms but less than severe NPDR. Severe NPDR have 4-to-1 rule. That is one or more of the following in the absence of PDR. That is, in the four quadrants with more than 20 intraretinal hemorrhages are present in each of the four quadrants. There is a definite venous bleeding in two or more quadrants, and there is a prominent edema in one or more quadrants. What is PDR according to the American system of classification is one or more of the following, that is extraretinal neovascularization, vitreous or preretinal hemorrhage. Diabetic macular edema is also classified as no apparent DME when there is no retinal thickening or hard exudates. Mild DME, there is some retinal thickening or hard exudates in the posterior pole from the center of the macula. Moderate DME, retinal thickening or hard exudates near the center of the macula but not involving the center. And severe DME, that is the retinal thickening or the hard exudates involving the center of the macula. What investigations, ocular investigations we can do in the case of diabetic retinopathy? Fundus photography as screening tool, conventional FFA, wherever we have a doubt of PDR setting in, even after photocoagulation, when we have a doubt whether it's unstable or stable PDR, wide field fluorescent angiography to look for the peripheral PDR, ultra wide field FFA of around 200 degrees area, OCT angiography, ERG, and systemic blood investigations can be blood urea, serum creatinine, urine albumin, HbA1c, BP, fasting blood sugar, and postprandial blood sugar to see the diabetic control. OCT is the investigation of choice for diabetic macular edema, and it is used for both qualitative and quantitative analysis of DME. What is it used for? It is used for telling the prognosis of the visual recovery. How it tells? Because there are signs of chronicity, like the outer retinal tubulations and the drill, that is the disorganized retinal inner layers, which tell us the sign of chronicity of the macular edema and tell us that the prognosis will be poor. And if there are signs of atrophy, the visual prognosis will be gross. And it also helps us to detect the surgical pathologies like the VMT, ERM, and various serous detachments. Like in this example, we can see the microaneurysm showing the leakage along with the macular edema with hard exudate. In this OCT, we can see the intraretinal fluid, the CME, cystoid macular edema with the intraretinal fluid along with the subretinal fluid. In this photograph, we can see the hard exudate plaque along with the intraretinal edema. In this, we can see the neovascularization arising from the RNFL layer and getting into the vitreous along with very mild preretinal bleed or leakage. In this photograph, we can see that it looks like a diabetic papillopathy, and on taking the scan of the area, we saw that there is a fibrovascular membrane over the disc, which shows that it is either regressed NVD. Next, we can do the investigation of ultrasound beam scans, which is largely helpful in cases of hazy media because of the large pH to see subhyaloid hemorrhage and the tractional detachment. What are the indications of doing fluorescein angiography when there is dense asteroid hyalosis to differentiate from severe NPDR from PDR? When the fellow eye has a high risk PDR and this eye might be uh, fusing, styling PDR, to differentiate between the optic nerve head vessels in the PDR versus the diabetic papillopathy in cases to see how much area is of the macula is ischemic. Macula, we have to look for the ischemia and the leaking microaneurysm. In retina, it is used to detect the retinal neovascularization and differentiate it from irma and evaluate the capillary non-perfusion area. So this is an example of FFA in a diabetic retinopathy case where we can see the leaking, there we see the microaneurysm, we can see very mild neovascularization and the big neovascularization area here. So it helps us to diagnose, and we can see the macular ischemia area has increased, foveal avascular zone has increased. OCT angiography is a non-invasive and it helps to have a detailed info of the foveal avascular zone to find about the vascular foveal ischemia, and it helps us to detect even the mild irma. It also helps us to delineate the capillary dropout zones, and it is the uh, it is the investigation which has the earliest detection of the microvascular changes even before the visibility of the microaneurysm. And the main advantage of OCT angio is it can be done on the patient with CKD and anaphylaxis to the dye. What the OCT angio can detect is microaneurysms, irmas, capillary non-perfusion, foveal avascular zone, NVD, and NVE. So this is an example of OCT equivalent to 12 montage of a PDA patient which shows extensive NVE. All these fronts we can see, which requires urgent laser therapy over this capillary non-perfused area. Pathological features in the diabetic retinopathy on fundus photography versus Whitefield slit, uh, Whitefield SSOCT. We can see, like this area, we can see the neovascularization here. We can easily see the neovascularization. We can also see the microaneurysms in the various areas, and we can also see the irmas from one vessel to the other vessel. We can locate all these things from the OCT angio, which might not be that clear on the fundus photography. The proposed staging system for the diabetic retinopathy using Whitefield Spectros OCT angio is no diabetic retinopathy. Subclinical DR, the foveal avascular zone slightly has increases in area along with few capillary non-perfusion areas. NPDR has lots of capillary non-perfusion areas. Pre-proliferative DR has irmas sitting in and lot of microaneurysms coming up. Then is the fusing PDR, in which the area has a neovascularization just starting. Then is active PDR, where the neovascularization is easily visible along with the capillary non-perfusion area. Extramacular TRD is totally non-perfused area of the membrane, along with what we see as a membrane here, along with neovascularization of the area. And this is the foveal TRD causing the traction at the fovea. We can see at the OCT that fovea is pulled from the traction. Fundus photography is used as a screening tool, as already told. It is used in various diabetic retinopathy studies, and it's a good tool to actually to educate the patient and explain the prognosis. And with this, we thank you. So the diabetic retinopathy uh, investigations are covered up along with the classification. Next lecture, we should have the management part of the diabetic retinopathy, and to all the DNPs who will be watching this, please, before the next lecture, we will have a 15-minute discussion about any doubts in this lecture, about any concerns from this lecture, and then we will move on to the next part of the management of diabetic retinopathy. With this, I sign off. Next Monday, we will meet again.